Our first speaker is Dr. JoAnn Manson. Dr. Manson is a professor at the Harvard School of Public Health. She's Chief Division of Preventive Medicine and Director of the Connors Center for Women's Health and Gender Biology. She's also the Elizabeth Fay Brigham Professor of Women's Health and Professor of Medicine at Brigham and Women's Hospital at Harvard Medical School. She received her bachelor's degree at Harvard, her medical degree at Case Western. She had a master's of public health and a doctorate of public health at Harvard School of Public Health. She's a recipient of numerous awards. She's published more than 700 articles and editor-in-chief of several textbooks. She was one of the physicians featured in the National Library of Medicine's exhibition. I think that was a typo on the first slide. That's of History of American Women Physicians, Bethesda, Maryland. And this morning she's going to talk about the Institute of Medicine's new guidelines for vitamin D and calcium intake, insights from behind the scenes. Dr. Manson.
Well, good morning. It's great to be here. As you all know, there's been a lot of controversy about vitamin D, and so what I hope to do with this talk is go behind the scenes with the Institute of Medicine Committee. I was a member of that committee that got new guidelines on vitamin D. And even if you don't agree with the IOM guidelines, I'm hoping that by the end of this talk, you'll at least understand why the IOM committee came to the conclusions that it reached. And you'll understand the process and some of the evidence that was considered in determining the recommended dietary allowances and tolerable upper intake levels, as well as the recommended blood levels to aim for in terms of managing or at least making recommendations for the public. I don't have any financial conflicts of interest. As I mentioned, I was on the Institute of Medicine committee that released the guidelines in late November. I have received funding from the National Institutes of Health, the National Cancer Institute, and the National Heart, Lung, and Blood Institute, primarily, as well as some other institutes, to conduct a large-scale randomized trial of vitamin D and omega-3s in the prevention of cancer and cardiovascular disease. This is a trial in 20,000 people. We're still in a recruitment phase, and I will tell you more about this trial, particularly in the second talk. So the goals of this presentation are to review the Institute of Medicine's recommendations for vitamin D intake, the role of both bone health and non-skeletal outcomes in the decision-making process. The second talk is focusing mostly on the non-skeletal outcomes, a little more detail, particularly about cancer, cardiovascular disease, but I will briefly mention some of those outcomes in this first talk. I do want to begin with a case study that we'll come back to at the end of this talk and just get your views on this. I don't think that there's an absolutely right answer. There certainly is a recommended answer in terms of the Institute of Medicine. But I want you to think about a patient who's postmenopausal woman, about 63 years old. She's African American. She has multiple risk factors for coronary heart disease, a fairly common constellation of cardiometabolic risk factors. You decide to check and screen for vitamin D deficiency because she has at least two risk factors for vitamin D deficiency, being African American and obese. Her vitamin D level comes back at 8 nanograms per mil. Now, to do the conversion, some of the slides, because we really worked with nanomoles, there's a 2.5 to 1 conversion factor. Usually the clinical labs will use nanograms per mil, but much of the literature will use nanomoles. So think about this 2.5 to 1 conversion. Where So multiply nanograms by 2.5 to get the nanomoles. So you start her on some vitamin D supplementation. Clearly her level is low at this point, but a really key question is what level of 25-hydroxy-D you should strive for this patient. And here are some of the choices. Should you just try to get her up to 10 nanograms or 25 nanomoles, get her up to 20 nanograms or 50 nanomoles, up to 40, or up to 60. So we'll be coming back to this patient. Now, here is what the Institute of Medicine recommended in terms of dietary intakes, and on the next slide, I'll show you the blood levels that are recommended. So you'll know the answer in terms of what the IOM recommended, and you can decide whether or not you agree. So overall, the guidelines for recommended dietary allowance, and by the way, what the recommended dietary allowance means is the level of intake that should meet the needs of at least 97.5% of the US and Canadian population. So these are public health population-based guidelines. And I want to make it really clear from the start that there is nothing about the dietary reference intakes that preclude clinical decision-making for individual patients. These are not the recommended intakes for someone who has vitamin D malabsorption, who has osteoporosis, who you're treating for a vitamin D-related disorder, or who is known to have increased needs for vitamin D. These are recommendations for a generally healthy US Canadian population. We do take into account obesity, though, and the very prevalent conditions in the United States. But again, it doesn't preclude your making individual decisions one-on-one, with a specific patient that you're seeing. But the recommendations we reached were that all the way from ages 1 to 70, 600 IUs a day would meet the needs for bone health. And as you'll see, it was very difficult to find rigorous evidence that vitamin D, higher intakes than this, would have greater benefits for non-skeletal outcomes. But we'll go through that as well. So the IOM did end up basing the recommendations primarily on bone health, because that's where the evidence was most compelling, and that's where there really was clear cause and effect relationship between vitamin D, together with calcium in most cases, and a clinical outcome. The tolerable, so for ages above 70, 800 IUs a day. Now, these are actually pretty large increases since the last guidelines in 1997, when only about 200 IUs a day, even though they're not directly comparable, but there is quite a substantial increase in the recommendation since the earlier ones in 1997. In terms of tolerable upper intake level, and this can be viewed as a level of intake that is associated with adverse events, above which there's risk of adverse events, and some adverse events have been identified. So for ages 9 and older, it's 4,000 IUs a day, and 2,500 for young children, 3,000 for children in the 4 to 8 age range. So these are overall the dietary reference intakes, the RDAs, and the tolerable upper intake levels. So how do these correspond to a blood level? Well, the recommended dietary allowance would correspond in the vast majority of individuals if people did have 600 IUs a day below age 70 or 800 IUs a day above age 70, they would achieve a blood level of 20 nanograms or 50 nanomoles, at least 97.5% of the population. Most people are not getting this much vitamin D at present, as you'll see in the next slide. But the tolerable upper intake level is 50 nanograms. So if you were to get above 4,000 IUs a day, you'd very likely be getting a blood